All right. Good evening.
Good evening, sir.
All right. You're welcome to our today's class.
Thank you,
So
sir.
today we'll take a look at AUM, action and uses of medicines. So as usual, we look at questions and discuss it and solve it and take it off from there. All right. The first question for the day says drugs are marketed by A, brand name, B, generic name, C, chemical name, D, none of the above.
Generic name.
Is that what?
Generic name.
Are you serious? Why? Why do
Yes,
you say so?
because if we are to say about chemical name, not everybody knows about chemical name.
Uh-huh.
So if you are to talk about the brand name differs with country, but aside the brand name, which differs with the country, overall thing that drugs is being known is with their generic name.
They are what?
Their generic name, not brand. Brand differs with country.
Get the question right. The question says drugs are marketed by A, brand name, B, generic name, C, chemical name, D, none of the above. Marketed. It's not say prescribed. Marketed. Okay, okay. Let it do this. What do you understand by brand name?
We are being taught that brand name is usually a name of the company that produce the a name the company that produced the drugs gave it to.
Example.
Then the example is Flagyl. The generic name of Flagyl is metronidazole.
Hmm?
Eh, the
Is that
generic
what?
name, the generic name of like paracetamol is acetaminophen.
Mm-hmm.
Yeah. So each country has their own. We're being taught that in Africa, generally, you can just go and buy paracetamol, but when you're in US or London, it's known to be acetaminophen.
Hey. What of the generic name?
Generic name is the main uh, content of the main constituent of the medicament of the drugs.
Mm-hmm. Chemical name nko?
Chemical name is the chemicals that is being used to produce the medicine.
You say what?
Chemical name is the chemical that is being used to produce the medicine.
Have you done this in the class?
Yes, sir.
And you're talking like this. Huh? Okay, as you said, the brand name is the name given to a particular drug by the company that's, when they formulate the drug as medicine, they'll give it a name, so that they can be identified with that name. Something like now, I may produce my own brand of paracetamol tablet or syrup or whatever. I may try to call it Chetamol. Chetamol it become a brand name, but inside that Chetamol is paracetamol. Now that paracetamol is the generic name. In the British pharmacopoeia, it is called just paracetamol. But if it is USP, United States pharmacopoeia, they talk of what? Acetaminophen. But you told them I'm talking about the same thing. Are we together? Told them I'm
Yes,
talking
sir.
about the same thing, but it's just the pharmacopoeia in use, the British way of their own nomenclature. American own nomenclature, they call their own acetaminophen. British own, British call their own paracetamol. That's why if you see some um some supposed paracetamol, if you look at it, mainly those that come from US, what you see there is acetaminophen, not paracetamol. But they're the same thing. It's just they based on their own pharmacopoeia. Is that clear? They're the same thing.
Yes, sir.
So either acetaminophen or paracetamol, that is the what? The generic name of that drug. That's the generic name. That one is just the name. The name, that chemical name of drug is actually, most of the chemical names are very, very long that you can't even, it's not what a lay person can pronounce. It,
Yes, sir.
it, it doesn't make sense to a lay person. So, because these drugs are going to be used by people, not only those that know chemistry, but also those that don't even know how to read and write, but they can easily say paracetamol. Even if they're calling it even if they're calling it paracetamol, no matter how they call it, they'll be able to say paracetamol. But not everybody can start calling the chemical name of a paracetamol. And most of this chemical name, if you want to write it down, I wonder the type of prescription sheet that they will use to write those names. So they have to look for a name that will be that very short and simple name that will be approved by the what? By the FDA on the process of drug discovering the drug and the drug development. So that once it's approved as the generic name, it will be a common name anybody can use. So, but chemical name talks about the chemical structure, mention the chemical component of that particular. You know what you did in your organic chemistry, the naming of organic compound. So they follow that same pattern in the chemical name of drug. So chemical name of drug is not really a drug that you use, a name that you should use in what? Prescription. It's not a name that you can use in what? Prescription. Now, with this I explain now, what do you think is the answer to this question?
Okay, sir. I maybe it's the
Huh?
marketed. The marketed that you're talking about, is it within the customer and the patient and the pharmacy?
That is where the issue lies now. That's how you twist the question. It will become brand name. But drug can be marketed under brand name. Drug can also be marketed under generic name, depending on the context in question. You know, the question is somehow, the question is not that straight. The question is confusing. So the drug can actually be monitored. I just like the way the question is, so you can think. Drug, that's how you look at the question. Brand name becomes the question, the answer to the question. Let's assume you are talking about maybe active ingredients being marketed. It's paracetamol, active ingredient. Anyway, it goes, it's paracetamol. So that becomes the what? Generic name. If you want to mute your mic, that's how you look at the question. Let's assume you are talking about formulations of paracetamol now. Formulations of paracetamol. Most time is marketed as what? Brand name. But not all companies market their own as brand name. So some market it as generic paracetamol. So sometimes the active ingredient itself is marketed as paracetamol, which is generic. Sometimes you also see some active ingredient marketed using their what? Chemical name. So actually, drugs can be marketed in 3 of them using the brand name, chemical name, and the generic name, depending on the context. So if you're talking about context of as I said before now, the formulation, the dosage form being marketed, you can market it as brand name, you can market it as what? Generic name. If it is active ingredient being marketed, it's marketed as what? Generic name. Or even chemical name, not as brand name. So, but the question did not specify, it just said drug and marketed. So based on the question now, all the options are correct. So the answer should be all of the above.
Oh, so I didn't hear well. I thought you said the last one is none of the above.
Yeah, I'm saying that. So based on how the question was, I wasn't the one that consulted the question. I just picked the question from somewhere, but I'm just answering the question with you. You know what I'm saying? So based on how I didn't modify it, I just picked it the way it is, and I like it. It will help us to do what, brainstorm together. So depending on the context in question. So all of them, because the question is somehow general. Because you can market active ingredients. It's not true.
Sure.
The same thing with finished what products. So all of them drug are marketed with 3 of them, depending on the context. So that options, the last option should be all of the above.
Okay, sir.
That's what the question is ambiguous. Nobody should be asking. Will ask you that type of question without making it clearer. But following the way it is, that last option should be all of the above. It should be all of the above. Then, but if you go clinically now, if you're actually going clinically, is brand name. Is that clear? Brand name, because
Yes, sir.
it's marketed under brand name. But based on the question, that question is not well proper. It's not was not constructed well. Based on that now, the answer is all of them. All of them drug and marketed with its names, depending on the situation on ground, on the context. Is that clear? So that's what
Yes,
I can
sir.
say. That's what I can say about that question. All right, question number 2. The name of the drug that describes its molecular structure. The name of the drug that describes its molecular structure. I've already answered this one. Is A, brand name, B, generic name, C, all of the above, D, none of the above. What's the answer? What's the answer?
Generic name.
Did you get the question?
So he said the name of the drug that describes its molecular structure.
Uh-huh.
A, brand name.
Mm-hmm.
B, chemical name.
Uh-huh.
C, generic name.
Uh-huh. No, I said A, brand name, B, generic name, C, all of the above, D, none of the above.
Molecular structure has to do with the chemical.
So what's the answer?
I think it's none of the above.
All.
None of the above.
None. Is it not none or all?
None.
Good. That's the answer. But once you say molecular structure, you are talking about the chemical name of that drug. And the chemical name of the drug is not in the option I listed. So that's why the answer is what? None of the above. Is that clear? So brand name has no business with chemical structure or molecular structure. Generic name has no business with what? Structure. So the answer is what? None of the above. Is that clear?
Yes, sir.
Right. The next question says, what one of these will not improve the probability of positive outcomes when treating bacterial infection? Do I need to write on the board?
I think the if you are dictating it, it will be lesser. It will be lesser work.
You say what?
It's better when you are dictating it
All
because
right. Okay.
you
No,
can
no
get
problem.
it two times.
Okay. No problem. The question says, one of these will not improve the probability of positive outcomes when treating bacterial infections. One of these will not improve the probability of positive outcomes when treating bacterial infections. A, early detection of infections. B, appropriate selection of antibiotics. C, optimization of dosing. D, empirical treatment from tentative diagnosis.
So you said that C is what?
Optimization of dosing. Optimization of dosing.
Then D.
D, empirical treatment from tentative diagnosis. What's the answer? What's the answer? Why are you keeping quiet? Did you understand the question?
Yes, sir. You said one of these will not improve the probability of positive outcome when treating bacterial infection.
Okay, so what's the answer? Okay, what do you understand by the question?
That one will not improve the whether the infection will be treated well or not.
Okay. Uh-huh. So what's the answer?
I think it's optimization of dosing.
The question says one of these will not improve the probability of positive outcomes. So what it means that which of them will not lead to, giving us high chances of positive outcome? It says early detection of infection. Do you think early detection of infection will improve the probability of positive outcomes?
Yes, it's early detection will improve it.
How?
If you detect infection early, you start
Uh-huh.
early by treating it. We start treating it early, and treating it early will make the infection to go.
Good. If you treat early, it will reduce the effect and also avoid complications. It's true. So remember the question says which one will not. So early detection can improve the probability. That's why A is not the answer. Is that clear?
Yes, sir.
Then B says appropriate selection of antibiotics. Will it improve it?
Yes, it will improve it.
How?
There are some infections that require a certain antibiotics.
Okay.
Yeah, so those kind of infections are being treated with a specific antibiotics because they've grown resistant to other antibiotics.
Okay. So that means if you select the appropriate what antibiotics, it will take care of the infection and the positive outcome will improve, right?
Yes, sir.
So that is more reason why option B is not the answer, because it is say the one that will not. So option B is not the answer. What of option C? Option C says optimization of dosing. What do you think about?
Optimization isn't it like talking about reduction of dosing, like not taking the actual dosage?
And now taking the right dose now, optimum dose. Is that
Okay,
correct?
taking
Yes, the right
the
dose.
right
Yes,
dose.
the right dose, so as to ensure therapeutic level in the system and avoid resistance. You know that there's what is called MIC in antibiotic treatment. We call it minimum inhibitory concentration. MIC, minimum inhibitory concentration. You know that antibiotics like something like paracetamol now. Yes, you may take it the subtherapeutic dose. The only thing that will happen is that the headache may persist, and of course, with time, if you take it again, even if you miss your dose and take it again, it will still take care of the headache. But for paracetamol, for antibiotic, it's not like that. When you take them, if the dose you take do not end up not giving you the MIC in the bloodstream. MIC means minimum inhibitory concentration. That means the concentration of the antibiotic that will appear in the system that will be available, that is enough to inhibit or even kill the microorganism. There's a minimum concentration that is expected of every antibiotic to appear in the system to be able to tackle this microorganism. But if you don't take, if the dose you take cannot even give you up to the MIC, it's a problem. Resistance will ensue because the dose that what enter the system will not be able to take care of the microorganism. So if you optimize your dose well, Optimizing your dose will help you to achieve the required therapeutic level of this antibiotic, and at the same time avoid resistance. So, and if all these things happen, if the therapeutic level is appear in the system and resistance is avoided, will it improve treatment outcome?
No,
Huh?
no.
Hey, you say what?
Sir, please come again.
Okay, I
Please
said,
repeat yourself. Uh,
you know, okay, what is bioavailability? Let's start from there. What is bioavailability? What do you understand by the term bioavailability?
bioavailability is the concentration of the medication to achieve its therapeutic effect.
No. Is that what we are taught? No. Let's assume now, if you take paracetamol now as tablet, right?
Yes, sir.
The paracetamol will enter your system. Enter the stomach, from your mouth to the stomach. It will be broken down. We call it the disintegration.
Mm.
After disintegration, dissolution will take place. The active ingredients will leave, which is paracetamol, will leave the tablet moiety, and it will be absorbed into your what? Through your what? Walls of your what? Intestine, through your GI wall. So when it passes through that, it will enter the bloodstream. Now go to the hepatic portal circulation and come back to the systemic circulation. That amount of the paracetamol, not the tablet you took now, but the amount that appear in the bloodstream, in the system, ratio of that amount that appear in the system to the amount taken gives you what? The availability. So if the amount that was in the drug, the medicine you took, is the amount that appear in the systemic circulation, that means that the bioavailability of that drug is 100%.
So,
But
sir, can I ask you a question?
ask.
Okay, now it means that it's not every drug you take. Like after it goes through all this process and enters the GI and where the therapeutic effect is supposed to take place, that means
Mhm.
there's every tendency that they will lose some.
Of course, now it's not everything that will appear in the system.
Okay.
It's only it's only intravenous drugs taken through that enter the bloodstream
IV.
directly.
Mm.
These are the ones that have bioavailability of 100%. Any other one, both the tablet to IM, not all injection, no, IM is IV that have 100% what bioavailability. IM
Bioavailability.
intramuscular does not have 100% bioavailability. The one you take through the mouth does not have 100%. It's only IV that has 100%, because it's the amount that enter the system that will you injected that will appear in the system. The amount that you injected that will appear in the system. Is that clear?
Yes, sir.
Now going back to what I was trying to explain, that if injection, if when it comes to antibiotic, you know that antibiotic is not like paracetamol. Paracetamol is not fighting any microorganism. So you may take paracetamol now and the headache subside you will stop it. Even if the headache comes again and you can take it, it will still bring it down. In fact, you're not even encouraged to take it for a long time. Once you take it, and the thing will go down. That's why you see some will tell you PRN when necessary. But it's not for antibiotic. Every antibiotic has its own full course. If the full course of antibiotic is 10 days, you don't take it to 2 days and stop. No. If you do like that, it will not help. The microorganism you are fighting will develop resistance because you are taking sub-therapeutic dose or even sub-therapeutic duration of what? Treatment. Now, I say something about MIC. MIC means minimum
inhibitory concentration.
concentration. Now, every antibiotic has its own minimum concentration. It will reach in the system, not the one you took, the one that appear in the system. The concentration that appear in the system should at least be up to the minimum MIC. Because that is the minimum concentration that can attack that microorganism. So if the one that appear in the system is less than the MIC, it's a problem. Because it will not be able to attack the microorganism. And if you continue, what appears in the system is automatically, once it's below the MIC, it's automatically sub-therapeutic. And if that happens, you are promoting resistance because the microorganism will grow resistance against that drug. That when you now want to use it again, it will not work. Is that clear?
Yes, sir.
Good. Now, going back to the question, to that thing, that's why. Let me now ask you a question again. Now, so what from what I said now, if you optimize your dose, that means what it means by optimizing dose is that you target the dose that will give you that bioavailability of the drug that at least will be up to the concentration in the system will be up to the minimum inhibitory concentration or more than it or more than. Is by optimizing the dose. That's when you can achieve it. Thereby maintaining the therapeutic level in the blood. And once this therapeutic level is maintained, that means resistance will be avoided. And I ask you a question. Optimization of dosing, will it improve treatment outcome?
Yes, it will improve treatment outcome.
But you said no before. I was shocked too when you said no. So, based on that, now, is C the answer to this question?
No, this is the answer.
C is not the answer. Why is C not the answer?
Because you're meant to take the appropriate dosage in order for the treatment.
What I have already explained. Optimization of dosing is a way of improving outcome. I agree. But based on the question, is C the answer?
No, C is not the answer because you said will not.
That's what I want to hear. That's what I want to hear. So C is not the answer. Let's go over to D. This says what? This says empirical treatment from tentative diagnosis. You see, is that the answer?
Yes, sir.
Why do you choose it as the answer?
So all other options is not the answer now. A is not the answer.
No. Tell me your reason. Which one is that one? That one is not the reason. What is the reason? CEO.
Can you say
CEO. Maybe anyway, it's because I am no longer with the people. Ask them, ask question or ask those in Fanaye. Ask them. Final year, now ask them. My questions, some don't have answer. So if you are taking like that, that means had even I'm there with you, you'll be having issues with my course because some questions will not have answer. So don't select your options like that. There are some questions you will see, there's some exam when you go, there's some questions will not have answer. And your ability to say the answer is not in this question means that you know it. So don't just close the eyes and choose anything. You should know the reason for every option. Why every option is the answer. Why you are choosing that answer. Don't just do elimination. Ask those in front of you. Some of my questions, no answer. I'll tell you if you know the answer is not there, leave it, don't answer it. Those that don't answer it, I will know. Those that will just go and be doing to burn, I will know. So why did you say that the D is the answer? Why?
So I stopped at that empirical treatment from 10th. I didn't finish it. Please tell
Say,
me the remaining part of it.
empirical treatment from tentative diagnosis. Empirical treatment from a tentative diagnosis.
So I'm having issue with this this word tentative diagnosis.
In fact, put your video. Let me even know what you are doing. Put your video. Let me know what you are doing. Let me know what you are doing. You say what? I'm not seeing your face well. You say what? You say what? What do you say? Unmute your mic. Unmute your mic.
Is the tentative diagnosis that's why I'm having issues. Empirical treatment. The tentative diagnosis, does it mean that there was no diagnosis at all?
Okay, let me explain.
Okay.
You know, sometimes you just look at, you go to hospital or to see a pharmacist. You talk about you say the symptoms. The pharmacist or the physician will look at you, take note of signs. What is the difference between signs and symptoms?
Signs and symptoms. Signs is what you can see.
Okay.
Then symptoms is the
Okay. I am your patient now. I am a patient. I now come to your pharmacy to see you. So what are my signs? What are the signs and what use me now to explain what is what are
if I
signs?
start if I'm seeing rashes on your skin,
Okay.
those are the signs. Then when you yeah, is the signs like
Okay.
rashes,
Okay.
boils,
Okay.
mm, yeah.
Symptoms income.
Symptoms is when I must have concluded on this particular the particular
Okay, now
infection.
Don't worry, let me explain. Signs, as you said, are what you see. Maybe I have my eyes, my the skin rash, or maybe you check my sac, my conjunctivitis in my eye. You see yellow sclera. I'm somehow pale. This is our signs. But these are what you can see, right?
Yeah.
Can you see my pain? My pain?
No.
Can you see my headache?
No.
Those ones are my symptoms. I am going to tell you my symptoms.
Oh, okay.
I'll tell you I have headache. It's symptom. You cannot see headache.
Okay,
I
so
will
the
tell
one
you.
that is happening inside the
I will
person.
tell you the one you cannot see. I am not to tell you. These are my symptoms. But the signs, once you look at me, as I'm coming entering your office, once you look at me, bam, you see the signs. So sometimes healthcare professionals, physicians, or even pharmacists, so sometimes based on the signs and symptoms, they may just give tentative diagnosis because of what you complain that it's malaria. They will start treating
Okay.
malaria without definitive diagnosis, going to lab, finding out what is
Mm-mm-mm-mm.
finding the sign. The definitive diagnosis is that what you see and what the patient, if what you are seeing on the patient and what the patient is telling you and what the result from the lab that's saying the same thing is definitive. But if you just look at the patient, he's weak, he's having headache, he has headache, fever. One last did you treat malaria? He will say, last year, do you sleep under mosquito net? He will say no. When do you normally feel? You say towards evening. Your mind is going towards what? Malaria, right? Malaria. Have you? It's okay. Oh yeah. Sometimes they will send the person to go for lab, but they will start prescribing anti-malaria for the patient. That one is tentative diagnosis. Is empirical treatment. That treatment you are doing that time is empirical. It's empirical treatment you are giving. Fine. Sometimes at the beginning, empirical treatment may serve. It may be okay, but it does not hold water for a long time because it may cause other issues, because it may cause issues. It may cause issues over time. So over time, it may cause what? Issues. So it does not guarantee positive outcomes all the time. It just initially, it may be helpful initially, then with time, it may other things may start coming in. It can even lead to wrong drug choice. True of us, because there are some of this issue that I share. In fact, this is what puts some people in trouble. You see hepatitis, you see typhoid fever, malaria. There are a lot of diseases that share the same symptoms. That if you base your treatment only empirically, you may end up, if you base your treatment only on empirical ground, you may end up choosing the wrong drug. And if you choose the wrong drug, you think that you are treating malaria where there is no plasmodium, at least clinical malaria. You are pumping anti-malaria without the person the person is being ravaged by hepatitis virus, hepatitis, or any other disease that share the same symptoms with malaria, and you think you are treating malaria. So wrong drug choice can lead to treatment failure. And if there is treatment failure, there's tendency for what? Resistance to do what? Coming. So that's why D is empirical treatment from tentative diagnosis, because that is tentative diagnosis that gives rise to empirical treatment. But if you tentatively diagnose without being definite on what you are treating, whatever you are treating is what? Empirical. And this empirical treatment does not improve treatment outcome. So that's why D is the answer. Is that clear?
Yes, sir.
Did I throw your balance?
Yes, sir.
Hope I'm not I'm not blowing too much medical
No,
jargons for
no,
you.
no, 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 sir.
But you understood what I said, right?
Yes, I actually try to explain that tentative in my own way because I was thinking maybe wrong, like just looking at the person and guessing the diagnosis
Okay.
without taking.
Okay. Coming from, let's look at it from English language. Tentative. If I give you a date for our lecture, or maybe I want us to go out or to travel, I will say we travel. Let's just look at Friday. I am not yet sure. So that Friday I gave you is tentative. I'm not yet sure.
Okay, okay,
I just fixed it for fixing sake. No, I'm not yet sure. It's not tentative. It's tentative because it may change. So most of the things you do, you see people when they go to hospital. Anyway, there are some things that make some physician to start tentative treatment first. Maybe the patient is down. He has fever. He's drawing temperature. They may, if they look at the symptoms and it's classical signs and symptoms of malaria, instead of telling the patient to go and start waiting for lab result to come out, they may start treating malaria and typhoid tentatively. Why they take the blood sample to lab, the patient, but they will not take the blood sample after the patient has started taking drug. Before the patient will start taking the drug, they'll take the blood samples to the lab and now give person the drug he will go home and be taking, waiting for the lab result to come out. But the patient will be taking those drugs empirically because based on the signs and symptoms they have noticed, they've pointed out. They will diagnose tentatively. So a person will be taking the drugs and be taking care of at least, if not for the signs and symptoms alone, for now, until when the result now comes out, they will not look at it. Sometimes the lab result will show the same thing that the physician tentatively diagnosed. And if that is the case, that the diagnosis will become definitive. But sometimes when the lab result may come out, there may be something additionally. The tentative diagnosis may still be part of the diagnosis, so they will just add one or two drugs to that one so that the patient can now continue. And in some situation again, they may change the one, they may tell the patient to stop taking that one that was prescribed because they have definitively seen what the issue is and now give you but they rarely tell the patient to go because they don't even know exactly what is wrong, and the patient may go into develop complications. So within those 2 days they're waiting for lab result, they will tentatively make some diagnosis and they start empirical treatment. Is that clear?
yes, sir.
Are you okay now with tentative now?
Yes, sir. I'm okay.
Good. In fact, most of the things they do in the pattern medicine and some community pharmacy, especially when the pharmacist is not around, most of them are what? Tentative. Because the patient will say, I have it. But some pharmacies still send you to lab anyway. But most of them are just tentative. So let's go to the next question.
Okay, sir.
Antibiotics can be A, bacteriostatic, B, bactericidal, C, A and B, D, none of the above.
You said B, bacterial what? Bacterial what?
Which option?
B.
Bactericidal. What's the answer?
Sir, please, C and D is what?
C is A and B only. D is none of the above. What's the answer? Are you there?
Yes, sir.
What's the answer now?
A and B.
Why do you say A and B? Explain.
Bacteriostatic. Although we've not been taught about this, but I know about static being one thing. It doesn't change. So it treats one. There's one that treats. Oh my God. There's one that treats one particular infection. There's one that treats variety of infection.
Don't worry, let me explain.
Okay, sir.
If an antibiotic is bacteriostatic, what it means is that it inhibits the growth of the bacteria. So it prevents bacterial growth. It brings it down. It does not kill it, but it slows down the growth of the bacteria. So it inhibits bacterial growth. So those ones that inhibit the bacterial growth are what? Bacteriostatic. But bactericidal are those that kill the bacteria instantly, especially those that destroy the cell wall. People are doing MCB 211 now, right?
Yes, sir.
These are things you should do your MCB 211 and even MCB 112. But MCB 211, what MCB 112 is just about the structure, bacterial, and all those. But MCB 211, you do antibacterial and antibiotics well in detail there. Yes. And
Yes, we
you
have
are,
it on our scheme of work. We have it on our scheme of work.
when are you people writing your exam?
February.
February. Okay. So bacteriostatic, those who inhibit bacterial growth, they don't kill. But bactericidal kill the bacteria instantly. And those ones that kill bacteria mainly target the cell wall. once the cell wall is destroyed, the envelope, the what put cover protect the what contains the bacteria, this thing is destroyed, is dead straight. But some we just go and be changing, by playing with the enzymes, inhibiting enzymes that helps in the one thing or the other in the system of the microorganism. They will slow down those ones slow down the what the growth. So that's what we mean by bacteriostatic and bactericidal. So like penicillins now, penicillins, those ones attack the cell wall. They kill the bacteria straight. Things like tetracyclines and some other ones. Yeah, those ones do not are bacterio bacterio what did I say?
Bacteriostatic.
Huh?
You said penicillin kills bacteria instantly.
So it's what?
That
It's what?
is bactericidal.
Good, bactericidal. And so what does it say about the one that are bacteriostatic?
You said
Huh?
that it inhibits bacterial growth.
Example, tetracyclines. Example. Assignments. Assignments. I just gave you two antibiotics now. I just gave you only two. One is bactericidal and one is bacterial what? Static. So which one it I say is bactericidal?
Penicillin.
There are a lot of penicillin. That's why they are called penicillins. Then we also have tetracyclines. There are a lot of other tetracyclines, but we have tetracycline. We also have tetracyclines, other drugs that are under tetracyclines. That's why they have the name tetracyclines. So those ones, they are bacterial static. They inhibit the growth. But penicillins are bactericidal. So I want to give you an assignment now. Go and find out, list 10 antibiotics that are bactericidal and 10 that are bacteriostatic. Anyone you mention, you say the class, then also tell me their mechanism of action. Is that clear?
Yes, sir.
In our next class, in our next AEM class, I'll give you 5 minutes to tell me about the assignment. Antibiotic or antibacterial that are bacteriostatic, 10. The one that are bactericidal, 10. Tell me their classes, the class they belong to, and their mechanism of action. Is that clear?
Yes, sir.
So that is the assignment for today. Then another assignment is the difference between antibacterial and antibiotics. State the difference between antibacterial and antibiotic. In our next class, I'll give you 5 minutes to talk about, to give you a presentation on them. Is that clear?
So you said the difference between antibacterial and antibiotics.
Yes. An antibiotic. Research on them. Please do a good research. Don't go to ChatGPT and copy and come and tell me. Just make good research. Anyway, I trust you. I know what you can do. So in the next class, I'll give you some time to talk about it. Is that clear?
Yes, sir.
All right. Any question?
Yes, sir. So I have a question. Oh.
I ask.
Uh, when at the beginning of the class, you made mention of some drugs that have paracetamol as the generic name.
Okay.
Like I think there's yeah. So then why paracetamol has acetaminophen as generic name.
Hmm.
So why don't they write generic name of those paracetamol as acetaminophen, since we all know that acetaminophen is paracetamol?
No, see what happened. US have their own, you know, just as we have British English, American English. They
Okay.
brought that same thing in the pharmaceutical industry too. So they call it, their own is acetaminophen, American own, but British own is what, paracetamol. Is that clear?
Yes, sir.
So
Okay.
that's what happened. So the world just allow it to be like that. Just like as you have your British English and the American English. Let me say something. Due to that confusion, do I say confusion? Because those things confuse a lot of Nigerians, and that thing is affect us even in our spoken English. Someone will say short knicker. What is short knicker? Short. One of them is British, but one of them is American. So we say bending corner. Did you understand what I'm
Yes,
saying?
sir. Yes, sir. Understand.
They are the two world powers now, so they do what they like now. So they have their own is acetaminophen. British own is what? Paracetamol. So if they mention acetaminophen, they are talking about the same thing. It's just American own and the British name. Is that clear?
Yes, sir.
All right.
So
Any
please,
other
can you repeat this last assignment that you gave me? I've forgotten one. You said antibiotics and what?
antibacterial?
Okay, sir. Okay, sir. Thank you, sir.
You're welcome. All right, please do the assignment to see you next time.
All right, sir. Thank you.
You're welcome.